I'm really privileged to have this opportunity to share thoughts on adult health and aging with OI. When I accepted the talk, I thought that's a slightly odd title. And then as I came to it, oh, I can see why this is in, because actually it's a really important issue. So let's kick off. So here are my declarations of interest. So I'm going to give an overview of healthy aging for about 5 to 10 minutes, and then spend 10 minutes of how it applies to OI. And I don't know how many of you are aware, but we are actually in the UN decade of healthy aging. And it's an international push to improve the environment and opportunities that enable people to be and do what they value throughout their lives, with a focus on aging. And there's a very important reason for this, is because around the globe, people are more likely to be older than younger. So the number of people aged over 65 is going to increase by 1/3 in this decade. And there's a real focus to add life to years rather than just add years to life. And they've got some nice points, because we can use these levers when we talk to the government and other policymakers, because the WHO does have weight in policy decision making. So concepts such as leave no one behind, enabling exchange between generations, support health for all people, and a clear recognition that more of the same will not be enough. So one of their key areas are these decade action areas, and they've divided them into four sort of themes. One is the age-friendly environment. How can we make our environments better facing and better suited to people as they grow older? The second one is really important, is combating ageism. It's often silently suffered by many people and really important. The third one is integrated care. And this is recognizing that as people get older, they need access to good quality care across a number of providers. Numbers of people for third sector, GPs, community services, and also hospital services need to provide more integrated care so they can work together to support people as they grow older. And then finally, providing good access to rehabilitation and long-term care is very important. And one of their current focuses is on social isolation. So we know that 20 to 34% of older people are lonely, and loneliness is probably causing shorter lives and damages physical and mental health. But one of the values of working through the WHO is it gives you clear interventions you can then try and bring in either locally, regionally, or nationally, such as befriending schemes, social skills training, cognitive behavioral therapy, and also going to your local policy and decision makers to say, hey, come on, we have a problem with social isolation in the elderly. What are you doing around transport, digital inclusion, and age-friendly communities? And one clear steer from this document is that it's going to take policymakers to change the landscape. We have to have really strong policies and laws, both within our organizations and within our countries, to tackle ageism, inequality, and the digital divide. And it really encourages us to look at what's working well everywhere else and try and implement it and scale it up, but also important to improve our research and evidence base for what the needs are as people age, and where's the evidence for what works best, and to work together within a global coalition. So one of the first questions I always like to do is try and define things. So what is aging? And it's actually quite hard to find a good definition. It can be simply the passage of time, but quite a sobering one I found on a website is that it's a biological process of growing older that means you're more likely to die. Quite negative in some ways, but it does bring in that it is a biological process and it is associated with an increased risk of death. Now, what have we learned about aging from the community? So this is around the world, but what we've learned is that aging widens the health gap. So this is from the World Health Organization report on aging and health in 2015. And you can see here the range of physical active capacity in people in 3 different groups. And you can see the range seems to be getting wider as you get older. So as you get older, there are some people who are actually as physically capable as they were when they were 20, whereas some have very little physical capacity. And what this report says is that you've got to watch out for aging because it can make the health gap wider. And often these are for reasons that are outside of the person's control or options available to them, such as where they live and other incentives. And it often reflects an accumulation of advantage or more concerning disadvantage. And this was really brought home by this another part of the report, which looked at life expectancy by deprivation. So here's life expectancy in years, and here's deprivation. And these people are the least deprived, and these people are the most deprived. If you look at overall life expectancy, you can see the people who are most deprived live fewer years compared to those who are least deprived. But what we really want is quality of life. So if you look at life lived without disability, it's much more marked. People who are most deprived have a much shorter period of time where they're living without disability compared to those who are least deprived. And this leads to the conclusion that people who live poorer lives die sooner and spend more of their shorter lives with significant limitations. So that's the general background of the aging concepts for the general population. How does it apply to individuals with OI? So the best data for this actually comes from Denmark. It's a relatively small country, but they've got excellent records. And they've done this very important study just over 5 years ago, where they looked at people who had a diagnosis of osteogenesis imperfecta between 1977 and 2012, and looked at their survival compared to 5 people of a similar age, sex, and location of living. And here you can see that the survival was shorter in people with OI. So women on average lived 7 years less, and for men it was almost 10 years, 9.5 years less. And they're able to look at why are people with OI living fewer years. Here are the causes. So if you look at the people who did pass away, OI in early life, because don't forget this is from 1977 when pediatric care wasn't as good as it is now, there are a lot of OI related deaths under the age of 6. Once you got above 6, it's really important to remember that the big cause of death are the same as in the general community. They're heart disease and cancer. And this is really important for the OI community, that we really have to focus, we make sure we don't throw the baby out with the bathwater, and we focus on general health recommendations. Make sure you've got a healthy heart and you're taking part in all the cancer screening initiatives and all the cancer prevention lifestyle choices you can. But when they looked at the causes of death that were different to the general population, 3 stood out. There was a 3 times higher risk of dying from lung problems, 4 times higher from stomach and gut problems, and they didn't know why this happened, but this could be because some of the painkillers we use, such as non-steroidal drugs, aren't really good for people as they get above the age of 70. And then as we know, there's a higher risk of fracture, and it's relatively small, but there was a 5 times higher of dying after a fracture. So that's survival. What about individual systems? How is that going to be affected by aging in OI? Well, here the data is less good. I will admit to that. So we've got a very old study from Patterson, unusual recruitment, basically asked people to report. And here we can look at fractures per year over the lifespan. And you can see, as you will all recognize, a big spike in fractures in childhood. It goes down, and then there's this increase as people get older, which is much more noticed in the women than the men. So we have this sort of pattern of fractures and bone health over time. But bones affect people in other ways. So the spine is very important, and we recognize progressive kyphosis as people get over, and scoliosis, which in addition to causing very troublesome back pain and limitations in range of movement, having significant effects on breathing. We've already mentioned breathing is big problem for people with OI with a higher risk than the general population. So a really good study for this is the really influential Brittle Bone Diseases Consortium study from the US, where they looked at 217 individuals with OI, and they looked at the lungs in two ways, and they found pretty much the same. So when you look at a lung, you can see how much air does it have, what's its volume, and how quickly can it move the air, so what's the flow rate. And in both cases, here I'm just showing the graph for the volume effect. You can see purple is the predicted or reference population. And then in red, you have the individuals with OI type 1, in green, OI type 3, and in cyan, this OI type 4. And you can see OI type 1s around the age of 20 start having a lower lung capacity, especially in the women compared to the men. It's much more marked in OI type 4. And the OI type 3 is very difficult to interpret because there's few data, and also it's difficult to understand what their predicted lung would be because we use size. But the general picture is in OI, the lungs are smaller, and they don't move air as well, and this gets worse at a much quicker rate as people get older. Another thing that we probably don't recognize very often is osteoarthritis. So osteoarthritis is a painful condition. It's really well treated with surgery, but there are lots of things people can do before surgery, such as physiotherapy and simple analgesic use. And this can be a problem in people with osteogenesis imperfecta because they might have a fracture that crosses the joint line or have a fracture somewhere else that means the leg isn't straight. And this leads to exaggerated loading or weight on this little joint, the knee joint, and leads to very advanced osteoarthritis. So that is also more common as people get older. And when we bring all of this together, some really good work that I was really lucky to work with Alex Ireland, a great researcher from Manchester, who used people in the RUDI study, and he was able to show that depending on the type of OI, there were significant impacts on mobility, especially compared to the reference population. So red are people with severe or extreme problems, and you can see the width of the height of the red bar gets a lot bigger with OI compared to the normal population. And he was able to show that both age and the presence of pain predicted worse physical function. And it seems to be getting much more limited quicker compared to the reference population. So that's a skeleton, but we all know brittle bone disease is more than just a skeleton. What about teeth? Well, here it's very difficult to find literature. We know that teeth are a problem in OI, but how much worse does it get with aging? And it's quite interesting. When they looked at it, there were three things they looked at, and it was only one of the effects of OI on the teeth where the tooth root becomes narrowed, what they call pulp obliteration, was much more common in older than younger people. And this is important for your dentist to know because it can make root canal work very challenging. Hearing. So just to recap, there's three broad types where your hearing can get worse. It's what we call the problem with the pathway or the canal, and we call that conductive. A problem with the nerves, and we call that sensory neural. We like big words. And then a combination of both, where it's both conductive and sensory neural. And a recent Brazilian study, yeah, I'm sure, Corinne, I'm happy to share the slides. I think I've already sent you the deck, but you can, of course, share them. A recent Brazilian study has really said that most kids are okay with hearing. In adolescents, it's more a conductive problem, but adults, it's this mixed or sensory neural problem. And this is important because hearing loss is very damaging for your quality of life. And we're quite prominent in how we assess hearing, and you should be having regular hearing tests as an adult, at least every 2 years, because you're often the last person to notice it. How am I doing for time? It's almost done. Okay, so what about other organs? So aging in the heart. So if you look at the heart, it's got three major bits. Oversimplification. It's got valves that make sure the blood flows in the right direction. It's got pumps that make sure the heart pumps well, and it's under electrical control. Thank you, Nick. Again, using this sort of Danish framework of study, they looked at people with a diagnosis of OI and without a diagnosis. diagnosis of OI, but of a similar age, sex, and where they lived. And here they found something really important. They found increases in both valve disease, pump failure, and abnormal rhythms based on whether you had OI or not. And here what I've said is the average age of the first problem. So in the upper valve, which we call the mitral valve, people getting problems at 63, whereas in the normal population of 75. You can see what it is for the other valve. And these are important because if you have valve disease, that can also affect your ability to function. You may get tired or breathless, and there are procedures we can do to repair this. Pump failure was a big surprise, happening much younger in people with OI. And here again, there are medicines that we can do, but we just need to have an increased awareness that this is more common. And then finally, rhythm failure was just a little bit earlier compared to the population. What I've put in here are the number of people with OI compared to people without OI who get this. So for every 1,000 people, 2 people would get a problem with the upper valve or the mitral valve compared to 16 with OI. 9 would get a lower valve or aortic problem compared with 2 with OI. Pump failure, much higher, 41 compared to 16. And rhythm failure, just under double the rate. But it says it's not going to happen to everyone. 16 per 1,000 is still, quite a low amount, but it's high enough for you to take note and to include it in your assessment as an adult when you're going for checks, because you may be one of those 16 in 1,000 who have a problem, and if you do, there are things that can be done. So I've talked about the organs, and one of the things that we don't know much about is occupation. So we know very little about how aging in OI affects ability for people to work, either in paid or unpaid voluntary work, because just being in voluntary work has a huge benefit both for society and also for the individual. We need more information about how bone pain and fatigue changes with aging and what sorts of fractures are occurring. And also, as I've already mentioned, the importance of the spine. And then as we get much older, we have to think about the lungs. And it's a discussion we sometimes have to face is the end-of-life care. There are some people who have very severe spinal disease where we have to think about what's appropriate to maintain their dignity and quality of life in their final 5, 2, or 1 year. So just for this bit, the healthy aging, how are we looking at it? Well, you can go online. The WHO have got great, easy to access documents. We have these 4 WHO targets, and the UK is part of the World Health Organization. And there will be a UK person, what we call a technical person, who works with the WHO. And maybe we should work as a community to make sure people with rare bone diseases, including brittle bone diseases, we're actually really pushing these targets for an age-friendly environment, combating ageism, which I see a lot and is really, really damaging for people. And we lose a lot of skill, integrated care and long-term care. Don't forget about general advice. We always focus on bone health, but the top 2 reasons for people to die with OI are still the top 2 reasons for the general population. So have a healthy heart, make sure you do lifestyle choices, and take part in cancer screening. That's really important. And just to flag that if you are on painkillers and you're slightly older, just check with your medical team. Is it appropriate? Is there something else I can be using? Then for OI specific, we have to think of the assessments based on age. As people get older, different parts of the body seem to be more vulnerable. We have the lifelong skeletal burden, that peak in childhood, and then the higher peak again as people get older. The impact of I've described on the lungs and the heart, and the teeth and the hearing. So I'll just close with a plug for research. So what do we need to know? I've already mentioned there are lots of things we need to know. And one thing we've been really lucky with the BBS is the COVID studies, which have looked through surveys of the impact of COVID on people's lives. So as you may know, I'm a lead investigator on this study called the Rudy study, and I'm really grateful for the over 200 people with osteogenesis imperfecta who've taken part in the study. We're really proud to have the BBS support this, and I'm just going to plug it for a bit because I think it's a good opportunity for us to maybe close some of these data gaps as people get aging. So I just pulled out where do our 270 people sit in terms of age bands. And as you can see, we're pretty well represented up to 49. Then it kind of falls off. And it'd be really nice to have more people who are slightly older who can take part in Rudy. It's super simple. If you can't access, well, if you're accessing the internet to watch this, so you're converted, but it's super simple to access and it's really easy to get involved. It's just online and it's been built so it's easy to complete. There are a couple of forms that we've got that we're actually actively looking for people to help with. So we've got a new COVID form that you can look at, but we've just put in this new valuation of lost productivity. And one idea we had is to look at the effect of aging on productivity. So how does aging affect people's ability to work in both paid and unpaid work? And so if you are in the Rudy study and you haven't filled in your questionnaires and you don't have much time, that'd be a good one to finish. And the other one, time's up, I've finished, is there's the fracture page. We put a link there. So I'll just finish with this. Healthy aging is a major public health issue for us all. Aging in OI does seem to happen earlier. It affects the bones, but also other tissues. There's general advice as well as advice specific for OI, and a plug for people to help us with the OI study within Rudy. Thank you, Nick. I'm happy to take any questions.